Ladies and gentlemen, welcome to the next session. This is a special lectures V2, Living and Winning with Osteoporosis. Let me introduce the speaker, Associate Professor Dr. R. Jayakanta Ratnasingham. Prof. Jayakanta is an Associate Professor at the University of Malaya Medical Center. He obtained his undergraduate degree from the National University of Malaysia and his master's degree in internal medicine from the University of Malaya. He completed his advanced training in endocrinology with the Ministry of Health Malaysia and had undergone a fellowship in endocrinology at the Princess Alexandra Hospital, Brisbane, Australia. He is currently a consultant endocrinologist and the head of endocrinology at the University of Malaya Medical Center. Besides managing patients with endocrine disorders, he plays an active role in clinical trials. He has published papers in academic journals and actively speaks at scientific meetings. Prof. Jaya is particularly interested in the field of neuroendocrinology, aiming at improving outcomes for patients with pituitary disorders. Let us welcome Prof.
Thank you very much, Dr. Allen, for that kind introduction, and good afternoon, everyone. I'm Jaya, and it gives me real pleasure to actually be part of the 10th Malaysian Hybrid Conference in Healthy Aging. I also want to thank and congratulate Prof. Shah on such a successful meeting. So I think I'm given an important task. I'm actually given the task to talk to you about living as well as winning with osteoporosis. As you all know, osteoporosis and fracture is one of the major problems that our aging population would face. So we are an aging population. I think you and I all are well aware of this. This is Malaysian data. You can see that the pyramid is sort of getting topsy-turvy a little bit. So this is on top is 2015. You can see that about 5% of our Malaysian population is actually above the age of 65. But if you project that ahead of time to 2040, it's expected that to actually triple up to about 15% in terms of our aging population. What we do know in terms of fractures, there's an increasing incidence that happens in terms of fragility fractures that increases with age. Here you can see the graph showing you in women on your left and in men on your right. You can clearly see that with age, as you get older, the risk of fracturing, the incidence of having fractures per 100,000 person years actually increases. If you note carefully, you can see in the pink bars are actually forearm fractures, or what we call Colles fractures. In blue are actually vertebral fractures, the spine fractures, and in green actually the hip fractures. And you can see here at a much younger age, about 50s to 65, just after menopause, women are actually at an increased risk of distal forearm fracture. Then on from 60 onwards, vertebral fracture, and slightly a bit older age group actually are more predisposed to hip fractures. And that rise actually is very exponential. It goes up a lot as you get older, above the age of 75. That's the green bars that you see. So why does osteoporosis happen? Because obviously there's a tilted balance in the bone metabolism between bone formation and bone loss. Bone is not a dead organ. A big bone is actually very much alive. And if you can see here in this cartoon diagram, on your left is actually normal bone, and on your right is actually osteoporotic bone. And if you can see here, there's a good balance between bone resorption and bone formation. Bone resorption is done by these cells that are called osteoclasts, and the bone formation by osteoblasts. If there's a balance, actually what happens is the bone remains healthy, okay, not osteoporotic. As we get older, what happens is the balance tilts a little bit, and there's increased bone resorption. The osteoclastic activity actually goes higher, and this osteoclast, what they do is actually they sort of mop up or eat up the bone, and because of that, the bone becomes more osteoporotic, as you can see on the diagram on your right. So bone loss obviously happens physiologically as a consequence of aging. It will happen to all of us, you and I. We can't run away from it. Both men and women are of course affected. And if you can see here in women, if you can see your graph on your left, you can see that the bone loss in women actually happens a little bit more drastically at the age of 50 at menopause. You can see where the arrow points there compared to men. Of course, the amount of bone that you have when you're older is also dependent on how much bone you actually have as a younger person. So what we call peak bone mass. So the peak bone mass actually peaks at about age of 30. That's why we tell our children and our teenage children as well as younger adults, you have to make sure that you have a healthy bone when you're young in order to actually reap the benefits of having a healthy bone when you're actually much older. So the higher the peak bone mass you have when you're younger, when you're in your 30s and your 20s, the more you will be left with in terms of bone as when you get older. So there you can see that the rapid loss happens on your right hand graph, a picture that you can see rapid loss happens immediately post menopause. And a bit of continuous loss happens even after that at the age of 60 and above, but that's a bit less rapid compared to the rapid loss that happens between 50 to 60 in women who just attain menopause. So just another reminder again that men are not spared. It happens in men as well, but a little bit more progressive because men do not have that sudden menopause event that unlike women. So osteoporosis is truly a big burden worldwide. This IOF data, this is not from me, International Osteoporosis Foundation says that worldwide an osteoporotic fracture occurs every 3 seconds. Every 3 seconds. So since I've started my talk already, you can imagine the number of osteoporotic fractures that would have happened. It would have been at dozens already, just in the 5 minutes I've spoken. Okay, it is said that this is a very nice poster that you can see on the IOF website, that it says during a season 1 in 4 rugby players suffer from an injury, but that's nothing in comparison to 1 in 3 women above the age of 50 who would suffer from an osteoporotic fracture. So if you look at it worldwide, again, just simply because we are an aging population, just like Malaysia, the rest of the world is also aging, and this actually times 1,000. These are actually incidents of hip fracture, 1990 compared against 2050 in red. Okay, you can see that the numbers have gone up, and the numbers are very markedly increased, especially in Asia, because we know that Asians are actually at a much higher risk of osteoporosis compared to the rest of the world. So in Asia itself, it's expected that with the steep rise of the aging population, as well as our inherent osteoporotic risk, okay, it's expected that more than 3 million people, women, will be affected by hip fractures here. Why are we so concerned about fractures is because both in men and women, fracture actually equals to reduced survival. Once an elderly person actually sustains a fall and an osteoporotic fracture, that actually means that survival would actually, that actually translates to reduction in survival. So if you can see here in blue is the Kaplan-Meier plot for the general population, okay, in terms of survival probability and the number of years. Okay, and in all the in the black and the gray shades are actually different types of fractures here. You can see here hip, vertebral, major as well as minor fracture. Just to draw to your attention that the hip fracture has the highest or the most more sort of significant in terms of mortality, because it reduces survival by about 5 to 10 years compared to a woman or a man above the age of 75 who has not fractured. So comparing someone in the general population without a hip fracture, if you compare against an elderly person with a hip fracture, that person with a hip fracture's lifespan is actually reduced by almost 5 to 10 years. So that's very significant. If they actually survive a hip fracture, okay, actually they still end up with quite a lot of morbidity. Okay, about 80% of them are actually unable to carry out at least one independent activity of daily living. About 40% of patients who suffer from hip fractures actually are unable to walk independently. Okay, and 1 in 5 of them will actually die within a year of hip fracture being sustained. So it's not only a high in morbidity, but also it increases mortality. What are the common osteoporotic fractures? If an elderly person falls down with osteoporosis, what are the sites that can be fractured? Okay, of course, as I told you, okay, in the sort of a youngish kind of elderly individuals, okay, those just after menopause between the age of 50 to 65 or so, the risk of wrist fractures or Colles fractures are quite high. So if they fall down, especially with an outstretched arm, okay, these individuals can sustain a wrist fracture. The second, a bit slightly more serious fracture is actually the vertebral compression fracture. This normally happens when they fall down on their buttocks. and they can actually have compression fractures in the spine, as you can see on this radiograph. Of course, in the slightly more older elderly individuals, those above the age of 70 or 75, okay, then there's an increased risk of hip fracture. This is, of course, the most grave or the worst in terms of consequence. And they can end up, okay, with all the morbidity and mortality, as I have discussed just a couple of minutes ago. The important thing, why should we identify all these fractures? Because once patients are admitted with fractures, definitely we need to start them on anti-osteo. We need to detect, okay, or diagnose osteoporosis if it's not been done before. And definitely they need to be started on treatments for osteoporosis. Why is the reason? Because we know that patients who actually have one fracture are multiple times increased risk of a future fracture. For example, here, if you see a lady who actually has a vertebral fracture, her risk of developing another vertebral fracture in the next 2 years actually 4 times. So if someone comes in with a L1 fracture, okay, in just say in January of 2022, and that person's risk is actually 4 times, okay, it's actually elevated by 4 times compared to someone who does not have a baseline osteoporotic fracture in terms of sustaining another fracture. Similarly, with terms of hip fracture as well, if you have one hip fracture, your risk to break at the other hip, the contralateral hip, is double, okay, compared to those without fracture. And the interesting thing is, the important thing is, we cannot delay in terms of treatment or identification, because it's known that almost 50%, half of all those recurrent or second fractures actually happen within the first 2 years of the first fracture. So how are we doing? If you look at worldwide data, these are sort of advanced countries. This is not, I've not shown you Malaysia yet. This is USA, Netherlands, and Belgium. Okay, and if you can see here, even in all these so-called maju countries, okay, advanced countries, you can see after a hip fracture in the US, after a low trauma fracture in Netherlands, and after a hip fracture in Belgium, very pathetic, small amount of patients are actually treated. A lot of patients are actually missed. So even they actually have a low trauma fracture, okay, either they have morbidity and they cannot come back for follow-up, or they are not somehow missed, okay, or somehow in terms of the fracture services is not up to date. They actually miss in terms of identification. People don't identify, even doctors don't identify these fractures as being osteoporotic fractures. They are not adequately treated. They are not given calcium or vitamin D. They are not given the active anti-osteoporotic treatments like bisphosphonates or denosumab or even teriparatide. So these are in sort of advanced countries. So it's only about, maybe at most, about 20% of patients who are actually treated, okay, after a low trauma fracture. So the condition is quite devastating. How about Malaysia? There's very little data. This is I plucked out from a publication in 2013. Just to highlight to you that only 44% of those actually after an osteoporotic fracture actually had a diagnosis of osteoporosis, and only 44% of them actually received a prescription. So 60% or 2/3 of patients are actually being missed. Even we as doctors are actually missing osteoporotic fractures. So how do we live and win? How can we overcome this problem? We know that it's part of healthy aging. I mean, it's part of aging. Okay, you and I can't escape osteoporosis. I mean, of course, we can prevent it by making sure that we have good peak bone mass. That's the best we can do in our younger days. We have to take adequate calcium, vitamin D, okay, have enough exercise, enough sunlight to ensure that our peak bone mass is good. But the rest of it are non-modifiable. Like, we can't change our gender, we can't change the time we actually achieve menopause, we can't change our family history of osteoporosis. Okay, these are some of the other risk factors. So how do we live and win with osteoporosis? As I mentioned earlier, we actually need to know how to diagnose and manage osteoporosis very well. If you're a physician, osteoporosis is defined as a skeletal disorder characterized by compromised bone strength. And in this situation here, bone strength, okay, is actually bone density together with bone quality. So what we measure in the dual energy X-ray absorptiometry, or the DEXA scan, you like to call it, or the BMD scan, the bone mineral density scan, is actually the bone density. But there's also another component called the bone quality that also affects bone strength. So we actually need to look into both bone density as well as bone quality. So what are the important risk factors? Of course, if you are a physician managing someone who had an osteoporotic fracture or with osteoporosis itself, you want to screen them for osteoporosis. Of course, you don't want to wait till they fracture. You want to screen them earlier. Okay, you want to look for any past history of fractures. You want to also look at risk factors for falls, because falls is also a very important risk factor for fractures. So whether there's any poor vision, instability, or neurological disorders. Okay, important to look at family history of osteoporosis and fractures. Okay, and the low peak bone mass, as I mentioned earlier, a lot of it is genetically determined, but of course, some of it you can actually modify with your lifestyle, and that has to start in your 20s or so. The date of menarche and menopause is also important. If menopause was much earlier and the woman did not take any hormone replacement therapy, of course, she's at increased risk for osteoporosis. Any history of taking steroids or traditional medications, smoking and alcohol, history of other endocrine problems such as thyroid, liver, renal, inflammatory bowel disease, and the level of physical activity and calcium intake is also very important. So these are some of the things that we need to look into in terms of taking a history or identifying risk factors for osteoporosis. What investigations can you do? Of course, the gold standard is the dual energy X-ray absorptiometry, or the BMD, what you'd like to call bone mineral density. Sometimes you can do it with and without a trabecular bone score. So densitometry or sometimes may not be enough. You may need to do a vertebral fracture assessment, which is sort of an X-ray to look at any fractures. Or if you don't have that, together with your BMD, you can also do a lateral vertebral X-ray. There's something called a FRAX score, which is actually calculating the fracture probability. And also, normally doctors would do baseline investigations such as renal function, calcium, phosphate, ALP, vitamin D levels, okay, your 25-hydroxy vitamin D. And sometimes, depending on the history or after examining the patient, you might also need to take some other specific tests to look for any secondary causes of osteoporosis. Some things like hypogonadism in a man, or maybe primary hyperparathyroidism. These are rare conditions, but sometimes can contribute to osteoporosis as well. So this is what the DEXA scanner looks like on your left. And of course, you I think would be quite familiar with the WHO classification for osteoporosis. I'll show it again shortly. So of course, what you get is a picture here. As a standard practice, most centers will do the spine, a central DEXA, which is actually the spine, as well as the hip. And here you can see in this patient, it actually falls in the osteopenic range, which is the yellow range. Of course, normal is in green. Okay, and in red, it's actually osteoporotic ranges of bone density based on WHO scoring. So who should have a bone density test done? If you are in general practice, or you are part of the public, or you're somebody in healthcare worker, or you're worried about your loved ones at home, how would you decide whether should I go get a bone density test done for that person? Of course, you can use this in for Asians. This has been validated. This is the osteoporosis self-assessment tool. So you can see here what you have in this table is actually looking at patient's weight, okay, and plotting that against age. So as you can see here, as you get older, and if you're lighter, okay, if you're underweight or lighter, if you're very thin, okay, and if you're very old, then of course your risk of having osteoporosis is high, which is the red zone, that is 61%. If you're somewhere in between, it's medium, of course in yellow, that's 15% risk, and low risk are actually those who are very heavy and those who are very young, and that's actually a 3% risk. So based on this OSTA, you can actually decide whether you want to measure BMD or not, okay? So in low risk, of course, BMD is probably not necessary unless you have other risk factors. In both high risk and medium risk, yellow and red, yes, a BMD is definitely recommended. Okay, in red, of course, you should highly consider pharmacological treatment. In yellow, of course, it will depend on the BMD, and then you would consider whether you need to do a pharmacological treatment. So for example, if you have a woman here who is 60, who is about, just say 52 years old, and she weighs 63 kilograms, she will fall in that area of the blue box there, versus which would be low risk, versus somebody who, just say if you have a 46-year-old lady who, sorry, a 76-year-old lady who's actually only about 46 kilograms, she would actually fall in the high risk. So she's definitely someone who you want to screen with a DEXA scan or bone mineral density, and consider starting her on treatment. Again, I will show you WHO criteria. Here you can see here osteoporosis is if you have a T-score. So T-score is actually the sort of standard deviation compared to a young adult, a 20-year-old adult, which is used as a reference population. So if you're lower than -2.5, that means if you're -2.6, -2.7, -3, or -4, then of course you have osteoporosis. You have severe osteoporosis if you're worse than -2.5 and you have already sustained an osteoporotic fracture. Osteopenia, or the borderline group, is actually those between -1 to -2.5 T-score. So the more negative your T-score is, the worse your bone is. Although I've said all of that, it's also important to remember that not all fractures occurs only with an osteoporotic BMTs. Here you can see here, okay, in the lighter shades of blue, in the bar graph, the lighter shades of blue are fracture rates, and in the darker shades of blue or turquoise, actually number of women with fractures. So although I've said the worse your BMD, so the more towards the right is the more negative your BMD, the worse your BMD, your rates of fracture is higher. But it's also important to notice that even in osteopenic ranges, quite a number of women actually fracture. So if you actually look at the number of women who actually fracture, quite a lot of them also fracture in the osteopenic ranges. So it's also important to look at women with osteopenia and sometimes consider them for treatment. So how would we decide? Okay, so we have bone density on one end. We also have this issue of osteopenia. So how we can actually decide on their fracture risk is actually to use this online calculation tool, which is freely available to all of you, you and I. So there's something called the FRAX. Okay, this is a WHO FRAX. Okay, it's from the website. Okay, if you just Google that, you can go into that website and it's freely available. And you need to fill in a questionnaire. And so basically, what you need to choose in terms of country and race is actually, of course, either Malay, Chinese, or Indian for Malaysia. And we do not have our own FRAX data validated here in Malaysia. But what we do is, because our population is very similar to Singapore, so we tumpang, okay, the Singapore FRAX calculator. So you have to put Singapore there as a country, and you put Chinese. For instance, if you are Malaysian Chinese, you put Singapore Chinese. Okay, here I put in the lady's age is 68 years old. She's a female. She weighs 49 kilos. Her height is 145. Okay, she did not have any previous fracture, but her mother had a hip fracture, so that is a yes. Okay, she also smokes. She's not on any glucocorticoid. She doesn't have rheumatoid arthritis. There's no other cause for secondary osteoporosis and alcohol consumption there. And then you can put in the femoral neck bone density. So this, mind you, that the FRAX can also be calculated without the bone density. So if you have the bone density, you can include the bone density, and you have these fracture rates in terms of 10-year probability. You have major osteoporotic fracture risk, which is 21% here, and hip fracture risk, which is 9.9%. So that's rather high for this patient. So some people also like to use the Garvan Institute Fracture Risk Calculator. The difference is this one actually incorporates falls within the last 12 months. So especially in the elderly individual, you can also use this Australian one, which is the Garvan Institute of Medical Research Fracture Risk Calculator. Very important in our aging population to pay attention to fall, because fall is an independent and important predictor of fractures. Okay, it is said that 50% of those above the age of 85 will at least fall at least once in a year. Of course, not all falls lead to a fracture, but almost all fractures are due to fall, especially if you look at hip fractures. So it's quite complex, of course, the interplay between falls and fracture. Here you can see, okay, many different things need to be addressed as well, including muscle weakness or sarcopenia, postural instability, if it's there, that needs to be addressed, medications used, dementia, vision, low vitamin D. Okay, all these, of course, can lead to fall. Okay, and of course, depending on the fall, descent and impact, okay, plus load, bone density, and other factors taken into account, that can lead to fracture. So fall is also a very important thing. On top of FRAX, so FRAX did not include falls. It's also important to look at falls as an independent risk factor for fracture. So now that we know, who is at risk, what is the pathophysiology, how to detect osteoporosis, how to decide on treatment, is the next question, of course. So NOF, or the National Osteoporosis Foundation, actually has this guideline. This is from 2010 and still applicable on whom to treat. So if you look at here, after excluding secondary causes, postmenopausal women and men above the age of 50 and older, if you already have a spine or hip fracture or any kind of osteoporotic fracture, they should be started on active treatment. If the bone density T-score is below -2.5 or below in the spine or the hip, then they're actually indicated for treatment already, which is the box on your left. Okay, if you have somebody with a T-score between -1 and -2.5, that's osteopenic ranges, then of course you need to calculate the FRAX score, and arbitrarily it's taken that if the 10-year risk of fracture is actually more than 3% in the hip or more than 20% for any major osteoporotic fracture. This you can get these numbers from the FRAX calculator, then you decide on active treatment for these patients. So before I go into the drugs, let me talk about non-pharmacological, because this is also very important. And here, of course, we have calcium, vitamin D, exercise, fall prevention, nutrition, and stopping smoking. So this is, of course, recommendation, okay, IOM recommendation in terms of the amount of calcium intake. Just to suffice to say, okay, that in women and men above the age of 50, the recommended daily calcium intake is 1,000 milligrams per day. Of course, does not mean that you need to take in 1,000 milligrams of calcium in terms of tablets. Okay, this actually includes dietary calcium as well as calcium supplementation. So depending on the amount of dietary calcium one takes, okay, and that will actually determine how much calcium supplementation is required. So calcium, okay, is definitely required for bone health. The other important thing for optimal skeletal health is, of course, vitamin D. You can measure vitamin D levels, and what we measure is the 25-hydroxy vitamin D. Okay, most of us follow the lower recommendation, which is the ENDOSOC or US Endocrine Society definition, and we want to aim for a vitamin D level above 30 nanograms per mil, which is equivalent to 75 nanomoles per liter. So to achieve that, most individuals, our especially Malaysian population, who are actually found to be D deficient, most of us actually need about 2,000 IUs of vitamin D, 1,000 to 2,000 IUs of vitamin D per day. The importance of vitamin D in fracture prevention, I'm just showing you one study here. Okay, this in terms of hazard ratio and the levels of vitamin D. On your left is hip fracture, on your right is non-vertebral fracture. As you can see, the better the vitamin D levels, the better or the lower the risk. Okay, the risk drops. Okay, it's actually protective for fracture events in the hip as well as the non-vertebral regions. Exercise, there's many studies in terms of exercise preventing falls and also fractures. And if you can see here on this graph, in terms of injurious falls, overall, they have listed down all this in this meta-analysis paper. Exercise definitely is protective against falls. If you look at fractures itself, similarly, exercise is also protective. Okay, it favors the use or the implementation or the practice of exercise, weight-bearing exercises, mainly in terms of preventing osteoporotic fracture. So preventing falls is very, very important in terms of preventing fracture, especially when we are dealing with our healthy aging population here. Okay, we definitely want to make sure that there's good balance in terms of exercise that also not only helps with osteoporosis, but also osteopenia or sarcopenia. Okay, you want to definitely, if you're a patient, talk to your healthcare provider in terms of assessing risk of fall. Are you at risk of falling down? Okay, need to review your medications with your doctor or your pharmacist, because some medications predispose patients to giddiness or drowsiness, or any other kind of side effects that can actually increase risk of fall. Important to check vision and hearing annually. Okay, get your glasses changed if it's required. Keep your home very, very safe. Do not have items on the floor or around you that actually predisposes you to falls and slipping and falling. And of course, it's important to talk to your family members for support. Okay, falls is not just a serious issue for seniors. Okay, but also everyone else in the family has to take care to make sure that the environment at home is actually safe for our elderly family members who are staying with us. So just a little bit about pharmacological treatment. I promise I won't dwell too much on this. On your left is actually what we divide it into is actually bone forming agents. On your left, you can see there are PTH or parathyroid hormone. What we have is teriparatide there. And on your right is actually anti-resorptives. Okay, the commonly used ones are bisphosphonates, which is alendronate, or IV zoledronic acid. Okay, which is given once a year. You also have SERMs or selective estrogen receptor modulators such as raloxifene. Okay, and you of course have denosumab as well, okay, which is a rank ligand inhibitor, and I've shown some of the pictures here. And the newest kid on the block in terms of pharmacological treatment is romosozumab, which has dual properties. Okay, it also promotes bone forming. It is also anti-resorptive. So the agents that you can use are either bone forming agent, okay, or which we also call an anabolic agent, or an anti-resorptive agent, or something that has combination action such as romosozumab, which is the newest treatment that we have. Suffice to say, that this forest plot basically just shows you that the vertebral fracture efficacy of all the different medications that you have. This is alendronate, residronate, zoledronic acid, raloxifene, tibolone. Okay, strontium is listed there as well, PTH and denosumab. You can see there, okay, that all these anti-osteoporotic treatments have very good vertebral fracture efficacy. They reduce risk of vertebral fracture, okay, in postmenopausal women here in these studies, but up to about 50 to 60%. Okay, very, very robust. Of course, some not as strong, some about 40 to 50. Okay, but some like denosumab until up to about 60% or so in terms of vertebral fracture risk reduction. Similarly, for non-vertebral, almost all of the agents are very, very useful. Okay, you can use any of them here. Okay, and except for raloxifene, of course, raloxifene actually crosses the line of unity. Okay, so that's mainly used for vertebral fracture only. We don't use raloxifene if there's a non-vertebral or hip fracture. Hip fracture data, you can see that alendronate, residronate, okay, denosumab have very good and robust evidence in terms of hip fracture risk reduction, up to about 40% or so in terms of reduction of risk of fracturing their hip if actually treated with these medications. So how do doctors decide on treatment? If I'm an osteoporosis physician or someone who actually is quite well versed with treatment of osteoporosis, or even if you're a primary care physician or a GP, okay, how would you decide on treatment? Okay, because there's only several treatments. You can decide based on these few factors. What is the age of the patient, the site of the fracture, renal function, and in terms of compliance. So if it's mainly vertebral, you can use all the agents here, raloxifene included. Okay, if it's hip, of course, you can't use raloxifene. You can use the other agents, bisphosphonate, denosumab, teriparatide, romosozumab. If there's renal impairment, okay, CKD stage 4, 5, okay, mainly is denosumab. Okay, if you are a bit younger, you can use denosumab or bisphosphonate. Of course, if you are already having severe osteoporosis, then you would use teriparatide or romosozumab. And of course, compliance is also important to look at. There's a new guideline by John Kennis, this in 2020. Basically, what we do nowadays, okay, this is a little bit advanced, but what we do nowadays actually is to risk stratify and then decide on treatment. So whether the patient is low risk, high risk in orange, or a very high risk in red. So this can actually be decided based on your bone density and your FRAC score. Okay, in all patients, you want to optimize calcium and vitamin D, exercise and fall prevention as what I have stressed. Okay, if you are low risk, then it's basically just reassurance, lifestyle advice, considering, okay, hormone treatment and SERMs, which is a raloxifene. If you're high risk, then of course, maybe bisphosphonates or other bone resorptive agents. Okay, if you're very high risk, that means if you already had a fracture within the last 2 years, you would want to consider using an anabolic agent and then followed by anti-resorptive, which means that, okay, the guidelines nowadays actually advocating the use of more high-end agents such as teriparatide and romosozumab as first line and then followed by anti-resorptive agents. So of course, I don't want to dwell too much into the complexity of this, just to give you an overview of what osteoporosis is like, and I hope you have benefited from my talk. And even if you haven't, make sure you know these key take-home messages. If you haven't been listening for the last 30 minutes, the key take-home messages that I want you to have is that osteoporosis occurs as part of aging process, okay, and often it goes unrecognized. That is very well known. So all of us, whether you're a healthcare provider or member of the public, or you're caring for someone at home, okay, is elderly, always think of osteoporosis, because that's also an important contributor to morbidity and long-term mortality. And not only that, it also poses a big financial burden, not only at an individual or a family level, but also because you may need surgery, you may need implants, okay, but also in a national level or a global level, okay, it actually is a health economic burden. Prevention is of course key. You don't want to fall. That's very important. Have adequate exercise, calcium and vitamin D. Okay, if you're younger, if you haven't reached that age yet, then of course try to reach a peak bone mass as much as you can. Okay, if you're 30 and you're listening to this, you still have time. Okay, bone density and FRAX are the two major methods of how we decide on initiation of treatment. Of course, non-pharmacological is as important as pharmacological treatment. There are many, and of course, fall prevention is also pivotal for fracture prevention. So with that, ladies and gentlemen, I thank you for your attention. And back to you, Dr. Allen, and I'm open to questions.
Thank you very much, Prof. Any questions? Okay, right. For virtual participants, please type into the chat box.
Hello, I'm Dr. Chani. But I just want to find out, is osteoporosis reversible?
So I think the concept applies. If you look at, I mean, of course, osteoporosis is part of aging. I mean, do know that physiologically we will all lose bone as we age. But if you look at in terms of how treatments work, they actually can improve bone density. There's enough evidence for that. So if you give a patient a treatment, you can actually sort of, in some way, you can actually improve your bone density. So I mean, you can consider that reversing osteoporosis.
Osteoporosis?
Sorry, I didn't catch your question.
How long can we use the various osteoporotic treatment?
Yeah, that's a very tough question. So it will depend on the class of osteoporotic treatment that you're using. So of course, if you look at the supplements that we give everyone, of course, the calcium and vitamin D, that goes on continuously. You don't need to stop that ever. Those are the building blocks of osteoporosis to prevent osteoporosis. But if you look at the treatments per se, if you look at bisphosphonate as a class, of course, there's a sort of a time duration in which you would want to stop or consider a drug holiday. So that's somewhere between 5 years, 5 to 8 years, and at 10 years, definitely you would want to stop the bisphosphonate because there's increased risk of atypical femur fractures as well as osteonecrosis of the jaw if you prolong it for too long. But all this has to be individualized, and it will depend on the risk stratification of the patient. If you look at denosumab as a class, there's actually no duration in which you have to stop. You can actually continuously use denosumab unless you are actually not finding any good response with denosumab. Then of course you will change treatment. If you are looking at teriparatide, then the treatment duration can normally is for 1.5 years or 18 months. It can go up until 24 months, and that's about it. That's because that's how the studies are done in the scientific studies that have been done. If you look at romosozumab, which is the newest agent that we have, that's only for 12 months. So in many patients who are on all these anabolic agents like romosozumab or teriparatide, they will need to be followed on with other treatments like bisphosphonates or denosumab.
Testing. Hello. Yeah, like to hear your thoughts on why the treatment rate is so pathetic.
I think that's a very you have made that very nice observation. Yeah. So of course we know that. I mean, and it's not only here in Malaysia. I mean, there's some data in Malaysia, but even globally, the sort of the realization that the fracture, patients come in with a wrist fracture to emergencies. Just say the lady could be maybe about 67 years old, and she comes in with a wrist fracture. Even at the physician point of view, or even at the doctor's point of view, there's lack of realization that this is an osteoporotic fracture. Normally the focus on fixing the fracture, putting on a cast or maybe an implant where it's necessary. But often, I think the realization and that this is an osteoporotic fracture definitely lacks. But that realization is improving now. I mean, more and more people are aware that these fractures are due to osteoporosis. It's part of aging, and there have been established fracture liaison services. So these fracture liaison services are teams that actually you normally comprise of nurses or doctors or other healthcare workers that can actually pick up and identify all these patients who actually had osteoporotic fractures and make sure that they have been investigated, bone densities have been done, and treatments have been instituted. I mean, that's the way forward in terms of reducing that. I mean, definitely we know, globally that is the case, but that's also improving now.
We'll allow one last burning question. So if none, yep. Thanks, Prof. Jaya. Thanks, everybody.
Thanks a lot, Alan. Thanks. Sorry, I can't join you all physically in Penang, but I wish you a nice meeting.